Welcome back, everyone. This is episode 3 of Ask Me Anything. This new series is all about answering questions on a variety of topics that come directly from you, the Pain Fix Protocol community, with the hopes that we can all learn from each other's experiences and from the information being shared here. Now, I've selected 4 questions for today's episode, so let's get straight to it. Question number 1 comes from Nancy Joe. She says, "Dear Dr. Whitten, I've learned so much from you. Thank you. Having a torn rotator cuff at 69 from picking up too many baby goats. I recently saw your video and was excited to correct my pectoral minor muscle. I have no posture issues or a forward head position. And while there's no doubt that the position of holding the door jamb that you demonstrate in the video would work, there's simply no way I can get my arm up that high. It's very painful when I even try, and I'm hoping that for those of us that can't get into the position that you show, that there are more beginning exercises that would allow me to work up to the ones that you demonstrate. The shoulder that's healing has always had a scapula that sticks out, and I could really use some guidance." Well, your thought process on this, Nancy Joe, is exactly right. When you struggle with an exercise in a particular form, there's usually a way that you can chunk it down into an easier form or go into a regression, as we call it, that would allow you to build up in a safe way. And so when it comes to the type of situation that you're dealing with, where you're having difficulty lifting the arm, which is very common with a rotator cuff tear, what we're going to do is we're going to bring that into a regression and keep the arm much closer to the body. So in essence, anytime you have a rotator cuff tear, you've tampered with the shoulder's ability to stabilize itself. So there's an instability problem. The further you get the arm away from the body, or the higher the arm goes, the more unstable it becomes, and so the more painful it gets. And so the regression here is fairly simple. All you're going to do is keep the arm much closer to the side of the body. So let me give you 3 ways how to approach this. First is using that exact same door jamb technique like I was demonstrating in the pectoralis minor video, except instead of being way up here, lining up those pec minor muscles, you're going to be way down along the sides of your body. And you're going to grab the door frame as low down as you can possibly get. You're going to position it approximately here, and I like to wrap only the first 3 fingers when I'm in that low position, and then you'll just come through the door frame like that. Now, you're not going to be getting very much of the pec minor involved in that stretch, but you're going to be getting a ton of the upper fibers of the pectoralis major. You're going to be getting long head of the biceps. You're going to be getting anterior deltoid. You're going to be getting a lot of benefit from this as far as bringing the head of the humerus back into the center point of the socket. That's going to help with stability of the shoulder, which will cut down on the instability, which will cut down on the pain, and that's what we're really after. So you would follow the same rules. You're going to go 60 to 90 seconds in that low position, and I would recommend that 3 times a day. Now, I was working with a patient just yesterday who has an active rotator cuff tear, and he was having the exact same problem that you talk about, and he actually wasn't able to do that low door stretch. And so instead of that, I gave him the stretch where you grasp your fingers behind your back like this. Now, you don't lift that high. I'm just doing it so that you can see over the desk, but you're going to have them positioned low behind you with the elbow straight, and then you're just going to straighten the arms, and your goal here, watch what my shoulders do, is I'm pulling the chest open. So that's directly counteracting that flared out scapula that you mentioned there. And then you'll squeeze backward, and you're going to slowly try and work your arms further and further away from your body. Now, the one mistake on this that I would caution you about is some people do it with the shoulders rolled forward, and that should absolutely be avoided. Your goal here is to pull your chest wide open and get those arms straight back behind you. And that, likewise, would be 60 to 90 seconds, about 3-4 times a day. And then the last technique that I want to share with you specifically for this problem is to bring blood flow into those external rotators, and you get a little bit of opening on the muscles on the front part of the body. Is you're going to stand up straight and tall. Again, open the chest. You're going to move the hand into what's called, or the shoulder into external rotation by turning your hand outward like this. So palms will be facing forward, and then you're going to make very slow, tight reverse arm circles, keeping the arm very close to the body. Remember, it's an instability issue. So if you can keep the arm closer to the body, you can sidestep that instability, and you'll be able to move the shoulder, hopefully completely pain-free in this position. I like to run 50 to 100 of these, and I'll do them 5 or 6 times a day just to bring in a fresh supply of nutrients to those external rotators, which is going to speed up that repair process and get you reaccustomed to moving the arm without having pain. Question number 2 comes from Ethna. She says, "Hello, Dr. Witten. I've just completed 12 rounds of chemo and I'm waiting for my results. But I've noticed that my toes, fingers, and nose are tingling. I've been told that it's nerve damage from the chemo. What can I do for this as far as natural treatments go? Please help if you can." Well, Ethna, I first want to make clear that this question is way outside of my wheelhouse. I am not an oncologist, nor by any means am I an expert in chemotherapy treatment or its side effects. So obviously I can't give any prescriptions for your situation, but because of everything you've been through, I'd really like to share a couple of resources with you. First, I did a little bit of digging and I found that the type of neuropathy that you describe, or nerve damage, is very common with people who have undergone chemo. It usually begins shortly after chemotherapy treatment is started, and then it tends to get worse with subsequent sessions. So with 12 rounds like you've undergone, it's very likely that what you've been told is completely accurate, and that is the source of your neuropathy. Now, the good news is that once chemotherapy treatment stops, many patients tend to recover their motor and sensory functions within several months. And so we'll be hoping that you fall into that category. That being said, there are a subset of patients where the symptoms can be permanent. And so there are 2 resources that I'd like to share with you. And of course, you will want to check with your oncologist or your medical team before implementing either of these strategies. Now, the first is a study that was published several years back in a pain management journal that talked about using supplementation with a high-quality omega-3 fatty acid to help speed the recovery from neuropathy. And they found fantastic results in regaining both sensory and motor function in short order, and they had a phenomenal safety profile. So I'm going to link to that in the description down below. And the other strategy that I would look at if I were you is PEMFs, or pulsed electromagnetic fields. There have been multiple studies documenting that PEMF therapy is extremely helpful in recovery from neuropathy and actually regenerating nerve tissue, which is something that is not easy to do. And again, fantastic safety profile. I'm going to link to 2 studies that document those types of findings in people with neuropathy. Again, make sure to share them with your medical team and see if they're appropriate for you before proceeding. Question number 3 comes from Donna. She says, "Dr. Witten, I have pain in my knees when I walk down steps or hills. This is the only time I experience this. What can I do to alleviate this pain? Thanks so much. Love your work." Thank you, Donna. This question is super direct and it deserves a very straightforward answer. So when patients come into the clinic and they have problems like the one that you described, usually what I find is a significant muscle imbalance in their lower extremities. Oftentimes they are very strong and very well developed in their calf muscles, the muscles that are responsible for plantar flexion, or bringing the foot down towards the ground, but they have limited ankle mobility very often, and they are weak in the muscles that dorsiflex, or pull the foot up towards the ceiling. The main muscle that's involved in that motion is the tibialis anterior, and so these people tend to benefit from a few things. Number 1, they need to work on their ankle mobility. And one of my favorite things for improving ankle mobility is just to engage in deep squatting every day. The other thing that they need to do is stretch out the calf and Achilles tendon. Sometimes the plantar fascia is involved. And then they need to work on strengthening the tibialis anterior with resisted exercises, pulling the foot and the toes up towards the ceiling. And then the other thing that these people tend to really benefit from is backward walking. when I put people on a backward walking program, I usually start them off with like 3 to 5 minutes a day walking on flat ground, and then I'll slowly work them up to the point where they're actually walking uphill backwards, starting off on a gradual incline and then working their way up into a steeper hill. This will help to build up the deceleration muscles that you need in order to walk down steps or hills without having that pain in your knees. Now, if you're going to do backward walking, there are a few things that you need to be aware of. Number one, you need to choose your location very carefully. Make sure that you're safe. Make sure that you're not at risk for getting hit by cars or having anything jump out at you. You need a place with flat, even ground, and it's very helpful if you can have a walking buddy walk with you. They face forward while you're going backward to keep you safe while you engage in that activity. The fourth and final question comes from Michelle. She says, "Hi, Dr. Witten. I love your educational videos. Could you please talk about what posture is causing sciatica pain in the buttock and leg, and what protocol to use to cure this nagging and painful condition? Keep on the great educational work and have a great day." Well, Michelle, this is a really good question, and it highlights a major problem with a diagnosis like sciatica in that it's a very non-specific term. The only thing that sciatica really means is that there's pain in the lower back, buttock, and sometimes down into the leg. But it doesn't tell you what the origin of that pain is, what's causing it. The medical profession used to use a term just like this to describe lower back pain. It was called lumbago. So anybody who came in with lower back pain, they were given a diagnosis of lumbago, but it doesn't tell you anything. It just describes a symptom. You don't have to examine somebody to give them a diagnosis of lumbago. They just come in and say, "My back hurts," and you write lumbago, but it tells you nothing. There are a million different things that can cause lower back pain. And sciatica is very similar to that. So if somebody comes in and they have lower back pain or pain in the hip or pain going down into the leg, they're often given a diagnosis of sciatica, whether or not that nerve is being encroached upon. And so when true sciatica is present, there is, like I just said, some kind of encroachment or impingement upon one of the lumbar nerve roots that runs down into the leg, meaning part of the sciatic nerve is being affected and you're getting those types of symptoms in true sciatica. But even that doesn't tell you enough because we don't know where that encroachment is coming from. It could be coming from a disc issue, a bulge or a herniation. It could be coming from an arthritic condition with degeneration or bone spurs. It could be coming from stenosis. It could even be coming from a specific type of cyst that grows on or near the nerves called a Tarlov cyst. There are even cases of sciatica that are caused by tumors. Now, those are rare instances, but still they have to be considered. My point here is that the term sciatica means nothing. It tells us nothing about what's causing the irritation or the encroachment on the nerve root. And so there's just no possible way to give a protocol or a set of exercises or even an ergonomic recommendation for somebody who has that type of symptom. I'll give you an example. So you can have a nerve root problem in the lower back that is triggered from a flexion-based activity, which is very common. But there are people who have sciatica-like symptoms who actually, their symptoms are resolved when they go into a flexion-based position. So what really needs to happen when a person has symptoms of sciatica, meaning that pain in the lower back with referral down into the leg or radiation down into the leg, is you need to have a very thorough assessment. Now, a qualified practitioner will bring you in and they're going to put you into different positions to help you figure out, like your question asked, what position is bringing on your specific symptoms. And then from there, they can lay out a treatment plan where they'll make ergonomic changes to your work habits or your daily habits as you go through your routine. They can make recommendations for specific exercises that are tailored directly to your condition, and they can, most importantly, give you positions or activities to avoid that are contributing to or perpetuating your problem. But all of that is predicated on a proper assessment. So my strong recommendation to you, Michelle, is to find a qualified practitioner in your area, see them, and then get a plan that is custom tailored to address those issues. That's all for this week's episode of Ask Me Anything. If you'd like to get your questions answered, just send the email over to support@painfixprotocol.com. Use the email subject line Q&A. If you don't use that subject line, there's a chance I might not see your email. But send those questions over, and before you head out of here, make sure to subscribe to the channel and hit that like button, and I will see you next week for another episode of Ask Me Anything.